All right, hello and welcome to all of you. We're going to go ahead and get started with building health in Wyandotte County. Hi, I'm Liz Harris. I work for Bike Walk KC. I'm the events and marketing coordinator. And today with me, we have Michael Kelly and Eric Rogers. We have Karen Campbell and Laura Steele, all from Bike Walk KC. We also have Julianne Van Loo, the new director of the health department in Wyandotte County. We're really excited to bring you this program today. The pandemic is accelerating many trends and big changes that were already in progress. Over the next couple of months, we are talking with leaders in Kansas City and the Kansas City area to find out how that acceleration is happening locally in transportation, health, equity, and sustainability issues that are core to Bike Walk KC's mission, as well as intersectional issues that often overlap with our work, including things like racism, housing, economic development, and more. I want to thank Commissioner McKiernan for joining us today. I appreciate all of you being here. We have some excellent folks from around the Kansas City area who are really excited to participate in this program. So I'm going to turn it over to our policy manager, Michael Kelly, and let him get us started.
Okay, good morning, everyone. Thank you very much for joining us for this conversation. And again, thank you very much to Julianne Van Loo for taking some time out of her schedule to speak with us today. We know that she's very busy working to address issues of COVID, as well as set a clear vision for Wyandotte County. So we wanted to start off by just letting Julianne kind of give an overview of her background. Julianne? Oh. Sorry about that, guys.
Okay, how's this? Can people hear me? All right, good afternoon, everyone. Thanks for being here. First and foremost, I'm not sure if the very many friendly faces and names I'm seeing makes me more or less nervous. So this is me giving permission to the many partners who are doing incredible work with us to jump in to my responses, to correct me if I misrepresent anything. There are so many people on this call who are doing incredibly important work. And so I want to acknowledge that and acknowledge that I do not have all the answers, and neither does the health department. But I am thrilled to be here. I'm thrilled to talk about COVID, but also about other things as well. As Michael mentioned, I've recently become the director of the health department in Wyandotte County. I think I'm nearing 3 months, not quite there. I moved into this role in the middle of COVID. Previously, I was with the health department for a couple of years in the role of planning and operations manager. So similar work. I've gotten to be very involved in the CHIP and a lot of strategic planning, a lot of organizational work, which has been great. And before that, I actually relocated from Minnesota, where I did a lot of work for a large safety net health system, running new community programs and that sort of thing. So I've gotten the opportunity to work in the clinical and public health realms now, which I think has prepared me for this role pretty well. But thanks, Michael.
Julianne, and so to kind of get us started, there are some folks on here who I know are not from Wyandotte County. So for those who may not be aware, would you be willing to kind of explain kind of the combined county-city structure of the unified government?
Sure, and as you allude to, there are others who can speak to this better than me, but more than 20 years ago, there was the decision made, and as someone newer to the area, I think it was the right call to unify the Wyandotte County government and the government of Kansas City, Kansas. And so we are now the unified government of Kansas City, Kansas and Wyandotte County. However, that didn't change much for the health department. We have always been a county health department and will be. That's actually the way it's set up in Kansas in state statute is that health departments cover entire counties and that their board of health are actually their board of commissioners. So a lot of that is dictated at the state level.
Interesting. Okay, very cool. And so kind of going off of that explanation of how the health department is kind of structured, beyond kind of the day-to-day functions that you do, can you tell us a little bit more about your high-level vision for what you want for the UG Health Department?
Absolutely. I love talking about this. And I know some of you have heard me talk about this a little bit before, so I apologize for the repetition. But the health department that I envision, and I think most of my colleagues in the health department envision, is one in which we prioritize policy systems and environmental change. So public health as a field, like almost every field, has seen an evolution over the last 100 years, right? And so we are now in what we call in Public Health 3.0. And what this means is that public health began in Public Health 1.0, where we really focused on those initial public health interventions that increased the lifespan of humans by about 20 years over a century. So we're talking fluoridization and pasteurization and seatbelts and those really fundamental public health interventions that have done tremendous things for our community. And that kind of segued into Public Health 2.0 towards the 1970s, 1980s, when there was this realization that various populations and demographics experience health differently. And a lot of that came out of the HIV epidemic and the understanding that risk factors are not the same for everyone. And that has really now evolved into Public Health 3.0, which is to say, it's our responsibility, especially as health departments, to be prioritizing health for those who are most at risk among us, to be tailoring health promotion and health activities to our entire community, and to be focused less on the individual. Now, I don't want to make it seem as though I'm not a huge proponent of vaccinations and family planning and STI and the very important clinical services we provide and that others in the community provide. But that in 2020 is not sufficient for a health department. So it's our job to act as a convener to be getting like-minded individuals and organizations like BIPOC KC, like many other on this call, to the table. It's our job to bring the data and the evidence and to have experts on staff who can analyze that data and help explain it to our community. It's our job to be an advocate for proven research-based methods of improving health in the community. It's our job to be helping infuse health into decisions that seem to be not related to health, right? And I know a lot of us on this call know a lot about social determinants of health, but my vision for the health department is that one day, any other department in the unified government is considering a policy change, and the first thing they do, or among the first things they do, is call the health department to understand what the impact may be on health in the community, right? So if we can get to that place where the health department is not seen as a meddler in other departments' work, and I don't want to say that across the board. There are a lot of people that value us already, but I think there's a lot of relational work to do to get to the point where people want our input and they want us to help them understand the health ramifications of proposed and potential policies.
Sure, absolutely. And kind of like to kind of go off of one of the points you were making there about how tying it to social determinants of health and relating it to other issues that may not necessarily seem within that sort of purview. Can you give us an example of something that you see that you've seen already, either before this particular position or in your previous work with the health department, that could kind of serve as an example of that?
Sure. I'm very proud of the way the health department advocated strongly for the Merck in downtown KCK, which just opened up last week and is gorgeous, and I'm super excited about it. But you know, the health department hasn't been able to fully staff positions to work on food, you know, across the board, but we did have a central role in advocating for that and helping to expand the larger community's understanding of why this is good outside of a business case for this kind of opportunity in KCK, that the walkability to have healthy, fresh food options in downtown KCK is 100% a public health issue and is something, and so now that it is up and running, our WIC department is working really closely with them to get them WIC certified now so that we can ensure that others who may not otherwise be able to afford it can access that opportunity as well. So opportunities like that again seem outside of the realm of health to some, but we know absolutely impact our ability to be healthy.
For sure. And kind of going off of that, like this kind of discussion around supporting social determinants of health and addressing some of the key issues that are unique to a place like Wyandotte County brings me to my next question, which is what are some of the key health disparities that exist in Wyandotte County at the moment?
not to sound negative, but show me a health-related statistic in Wyandotte County and I will show you a disparity. That's the reality that we're talking about. So you can list off clinical indicators about STIs, about infant mortality, about diabetes, about heart disease, about cancer, death, and prevalence, and there is a disparity in every single one of those situations. And so, I mean, first and foremost, we're seeing that in the clinical outcomes in our community. But upstream from that, and to get back to the social determinants question, we're seeing drastic disparities among our social determinants of health, which are the reason we're seeing then those clinical disparities, right? So we see different rates of high school graduation. So if you want to talk about the role that education and employment plays in health, those differences that start really early on, as early as age 2 or 3, when we know our kiddos are receiving access to different levels of quality childcare, plays out in later education, plays out in employment opportunities, right? So it truly is as far up as the river as you can imagine. The disparities are embedded in our community. And I know you know this, and I know a lot of other folks know this, but that is rooted in the historical redlining and other racist practice that happened in our community and continue to happen to some extent. I think one of the areas that I have a particular passion for and am hoping that the health department can really get significantly more involved in is the situation with violence in our community. We know that impacts obviously our physical safety, but it impacts so much more than that. Excuse me, it impacts our emotional well-being. It impacts the trauma that can have physical and mental, emotional ramifications for our entire lifespans. And the fact that the leading cause of death between age 15 and 44 in Wyandotte County is homicide is not only important in itself, but twice as high rates of homicide among the Black population as the white population for age 15 to 24. So, you know, the health outcomes across our county are poor and need work done, but you know, we have to prioritize those populations that we know are most at risk and most vulnerable. The other thing I want to say while we're talking about health disparities is, first and foremost, racial disparities is usually where we kind of hang our hat. And I want to address that in just a moment, but there are other disparities as well. There are age disparities, there are income disparities, there are disparities related to disability that sometimes get forgotten. And so those are a piece of the picture that I don't want to leave unspoken to. And then lastly, this thing has been happening in our country lately that's driving me crazy. And we continue to call race a risk factor. And the truth is that there are an extremely limited number of health conditions and health outcomes that have any actual predisposition based on race. The truth is that racism is a risk factor for health outcomes, and that's playing out in our community. And so I think we're not going to make a lot of progress until we're willing to call that out and have that conversation.
Sure, and thank you for speaking to that specifically. I know that a number of people who were registering for this spoke specifically to the need to talk about both racism as well as health equity. So very much thank you for that. And if I could sort of tack on a little bit onto that. So when we talk about racism as a form of racism as a risk factor, you've mentioned things like violence, like health disparities. Can you, and I know this can go a number of different ways, but kind of briefly, would you be able to kind of give an example of how racism serves as a health factor that can actually lead to greater instances of things like violence or an increased risk of these physical conditions such as diabetes or heart disease that we know come from things like a lack of disinvestment?
That's a great question, and it's something that we're just starting to grapple with at the health department, because I don't feel like we have any clout or ability to talk about this in the community unless we look internally first within our own doors, right? And so we're trying to figure out how to do a much more robust health equity audit of our own programs and policies. But this plays out every single day when bodies walk into the health department and come to our front desk for an appointment. Is every human being that shows up treated the exact same way? I can guarantee you they are not. And I mean, no disrespect to my colleagues in the health department, this happens everywhere. And so whether or not we are making a safe and welcoming place, whether or not someone feels valued, whether or not they feel like more than a number and are respected, that is racism. And that is what leads to somebody wanting to come back and receiving follow-up care or deciding not to. And that can play a huge role. That can mean, you know, intensified STIs that they then pass on into the community. It has ramifications that we can't even see. And I think it's really similar in educational and business sectors. Are we making these places, do Black parents feel as comfortable going to their teacher or their principal, whomever, to talk about an IEP for their student as a white parent does? Have they been given the education or the knowledge about how to access particular resources that others who are more affluent or have internet connection or a whole bunch of resources are? So I think it really plays out in how are we making people feel? How are we ensuring that they know what resources are available, and not just handing them a pamphlet, right? How do we actually make that connection happen, right? And so I think racism exists in every single one of those systems, and it's our job first and foremost to look at ourselves and what we're doing and not doing.
Right. And that kind of leads me into one more question I wanted to ask before we move on to some questions about COVID, which is you talked a little bit about this internal consideration of what Wyandotte County is doing, not just in terms of like personnel, but also in terms of kind of the environment that we're creating to allow people to either thrive or inhibiting that in some cases. In your view, what do you believe is the role that infrastructure is playing in addressing or hindering some of our work on these issues?
It's a great question, and there's so many pieces of infrastructure, right? So there's very obviously the physical activity or ability to partake in that within our environment that impacts health kind of the most closely, right? So you can understand very easily why parks and trails and sidewalks have such a close connection to health because of the physical activity piece and all of that. And the health department has been working hard on trail expansion and those sorts of activities for years. But I think there's so much more beyond that as well, right? So there's our public transportation system. Is that facilitating our Eastern County residents being able to access those higher paying jobs in the Western half of our county? No, it's not. And we know it's not because we've done an assessment and we've seen it, right? So pieces like that. And to go back to the healthy food conversation as well, right? Is that infrastructure in place in a way that's actually accessible for people? And there are a lot of other built environment pieces too. You know, we do septic inspections in Wyandotte County out of our environmental health division, and there have been code changes over the years. And as there's a certain kind of year range of houses that were built whose septic systems are all starting to die, and to upgrade to these new septic systems in compliance with our county ordinances is an incredible amount of money. And so we're now grappling with, okay, that's a piece of the built environment. We have to keep our groundwater and our residents really safe from that. But at the same time, are we doing it in an equitable way? We're helping people figure out how to incur that cost to keep their community safe and stay in their home, right? So there are some pieces of, you know, physical built environment that we have more of an ability to play a role in than others, kind of on the real front end. But there's a lot of ways on the back end when we should be getting more engaged in the policy pieces. I am very hopeful. I hope many of you are getting to know Gunnar Hand, our new Director of Planning and Zoning, who as soon as he was able, called me directly and said, we're starting to work on the Armourdale master plan. The health department needs a seat at the table from the very beginning. And so that is super encouraging to me because it's saying people are understanding that there's a role for us in this conversation and not in the back seat, but as a driver. So there are really infinite ways that we can be working on the built environment. Obviously, the resource challenge will always be our greatest challenge. But I think collectively, and even with a number of folks on this call, we're starting to make incremental changes, which I don't think should be undervalued.
Absolutely.
Can I answer your question? I'm sorry.
Yes.
So feel free to do that.
That was a very, very good answer, and it's something that is not easily sort of fit into like a 30-second soundbite. So you did very, very good with answering that question. So I really appreciate that. So I'd like to shift gears and talk a little bit about COVID, because I mean, that's the reason that we're meeting in a virtual setting, is because of this pandemic. And I think it's very clear to most of the folks on here that this has had, unfortunately, an outsized impact on Wyandotte relative to the rest of the region. And so my first question along those lines is, how has Wyandotte dealt with the pandemic up to this point? And what steps are being taken by the health department to help stop the spread of the virus?
It's a great question. And I think first and foremost, I owe a shout out to the entire unified government. Um, However you feel about the unified government, I can tell you today that as a director of the health department, I have received what I believe to be more support and more reliance on the data available to us than I believe the vast majority of health department directors, not just in the metro, but nationwide. So the mayor and Doug Bach and our commission have made it clear that they expect us to follow the data and the science. And that I cannot explain how valuable that is, that we have never had to run from the science or politics or compromise what we believe is an appropriate response. So that has meant everything to us. That has allowed us to pretty right out the gate decide we have to do testing at the health department. We don't have a choice. So we jumped into that. I think 2 to 3 weeks after our first, 2 weeks after our first case in Wyandotte, we were, I believe, the first health department in the metro to be doing routine testing. Obviously, contact tracing, a lot of you have heard that term recently. That is the job of health departments. We have scaled up from a team of 1.5 investigators for COVID to 15 who are working day in and day out and on the weekend to contact trace. We put together the Health Equity Task Force, which we know is not complete, and there's a lot of work to be done there, but they have played an instrumental role in ensuring that the pop-up testing happening in our communities is happening in the right areas and is targeting those populations that we know often experience barriers to care. So I'm extremely proud of the work that they have done collaboratively without a lot of money, figuring out how to just make it work. That's been incredible. Our health officers, if you don't already know them, Dr. Alan Greiner and Dr. Erin Corvo, have been incredibly proactive in their willingness and ability to issue health orders, which not all health officers feel that comfortable. So the initial stay-at-home order, to the mask order, to the recent order delaying in-person education until after Labor Day. All of those are to some extent political risks for us and for them, and they have been willing to do that because they know that it's what the science says can help us, right? So across the board, we have been as proactive as we possibly could, and every single health department every single employee in the health department has stepped up and is spending almost all of their time on COVID right now. So I want to give them a shout out too, because we have folks in 95-degree heat out in our parking lot in full PPE for days and days on end, and that is hard work. It's also very hard to call people to do contact tracing and get yelled at and want to continue to do that. So, you know, they've had to persevere, and so my hat just goes off to everybody working in this building right now.
Yeah, absolutely. And we definitely want to recognize all the hard work that you and other health employees across the department, but also across the region have been doing to try to keep this virus under control. There was, I know we will get to all of the questions from people, but there was a question that we do have that I think could be good to sort of help explaining your approach, which is someone wanted to know a little bit more about contact tracing. So would you be able to kind of explain in layman's terms what exactly contact tracing is and how it's helping you to fight this virus?
Sure. So what we're trying to do is trace the spread, right? And head off cases before they become cases. So as the health department for the county, we receive from the state health department test results for every single test, right? So we have the names of every person. It doesn't matter if you've been tested at the health department or somewhere else, we end up receiving your test results a day or two later. And we, within a day of receiving those results, we contact that positive case. We let them know. Oftentimes their provider has told them that they're positive, but we confirm it with them and we provide them with guidelines and requirements for quarantine and isolation. And then we ask them to think really hard about everybody that they were around when they had a symptom and 48 hours before that as well, because we know you can shed the virus before you're experiencing symptoms. And we ask for all that contact information, and then we contact all of those individuals. So you can see quickly how one case can turn into 20 phone calls where you're providing all of that guidance and guidelines over and over and over again to those individuals, to ask them to quarantine, to ask them to wait until days 5 to 7 to get tested, because you can get a lot of false negatives if people run out and get tested prematurely. So helping them understand what to do if their test result comes back positive or negative. So it's really the process of epidemiologically tracking the spread, trying to get out ahead of those contacts of positive cases and helping them make really smart decisions to keep themselves safe and then the people around them.
Sure, absolutely. And thank you for that. And so it kind of speaks to a little bit to kind of the one part of the myriad of challenges that you are still facing in the midst of all of this. So in your view, and I think you've talked about this a little bit already, but what makes the work of the health department easier or harder because of how you're structured in terms of how you're dealing with this virus?
In terms of how I'm structured, can you?
Because you guys are a county level health department versus something that might be more localized to a city, for example.
Sure, sure. It is a little bit tough. It's hard to balance this sometimes because from my perspective and when I look at the data, I know that there are areas in my community that are more vulnerable, that need to be prioritized, that need to have better access to testing than others. And not everybody in our community wants to hear that. And our goal is not to leave out people in our community. It truly is not. And so we are kind of constantly thinking about, are we reaching that western part of the county? We have not done as much testing out there, and we're trying to figure out if every couple of weeks we can get a pop-up testing site out there. So, everyone is not going to be happy because we're not going to provide the level of service equally across our county. But I believe that it's appropriate that we don't provide the exact same level of service across the county, because if we do, we're never going to make a dent into the health disparities we spent so long talking about, right? So it's tough, and politically it's tough. And I'm attempting to burn no bridges, and I want to foster collaboration and partnership with all parts of our community. But at the end of the day, it's also our responsibility to prioritize resource allocations to the areas we believe need it the most.
Absolutely, absolutely. And kind of to go off of that, because I think that is kind of an important point and distinction to understand with Wyandotte, is that there is kind of an Eastern Wyandotte and there's kind of a Western Wyandotte, in that a lot of the disparities that we see tend to be in the eastern half of the county. And so can you speak a little bit to kind of what is kind of necessary to be able to navigate that sometimes fraught political element of what is a public health crisis?
That's a good question. A lot of relational skills that I'm continually working on. No, I also have the support of Gordon Criswell, who's an assistant county administrator, and of Doug Bach, our county administrator. They actually have intervened with me a couple of times to help make sure that all of the jurisdictions understand that, even if testing sites aren't in every community equally across the county, that doesn't mean that they're not benefiting from health department work, right? So every case we identify business benefits the entire county. Every case that exists in Bonner and Edwardsville, we are contact tracing, right? And our services, providing a community health worker, bringing food or cleaning supplies to someone's home, those are available to everyone in our entire community, and they are offered at the same rate to everyone who tests positive. So we do try to make sure that to the extent we can, every service is allowable and available for everyone. It's just, it happens in a little bit different way, and we are more proactive in some communities than others because we know that it's the right thing to do.
Sure. And I think that kind of gets into the last question I wanted to ask before we begin to move a little bit more towards the audience part of the questions, is that there things like having sort of walk-up testing sites and additional services and resources that you offer is something that seems a little bit unique for a place like Wyandotte, and it's a good approach. But would you be able to speak a little bit more to some of the additional steps that you're taking that are kind of specific to Wyandotte to try to better serve the community in this moment?
Yes, I appreciate you bringing that up, because when I kind of gave an overview of our COVID response, I did leave out some of the social response. So about, I think 2 weeks into our first COVID case, when we were up and running and testing and our contact tracing was underway, we started hearing some ad hoc reports that these folks cannot isolate and quarantine unless somebody's going to bring food to their house, right? And so I'm not kidding when I say out in this hallway outside my door, Wesley McCain and I stood there, pulled a whiteboard into the hallway and mapped out, okay, how do we put a form online that anybody in the whole county can request a food box? Where does that form go? How do we get cross lines to help us? How do we get volunteers to take this food out to people's homes? And so that's been our approach from the beginning, that that the health department and the public health system is not only responsible for contact tracing and testing, there is a social piece of this, which we knew at the very outset would only ever get worse, right? We knew that was coming. So we started first and foremost with food and cleaning supplies and some hygiene supplies as well. We've had incredible partners with a number of folks who have helped us. We've done our best to funnel volunteers to those organizations that we knew were benefiting Wyandotte County really strongly. And then we've also since then hired 3 community health workers on staff. So every person who's contact traced gets connected to one of those, and they speak a host of languages, including Spanish, Swahili, Nepalese, Burmese, which is really great. So beyond the food and other basic necessities, you can get a community health worker to help you with unemployment benefits, to help you with accessing insurance, whatever it is. So that piece again, where we know it doesn't just matter if the resources are there, it matters if people know how to get to them and can do so. So that's really been kind of at the backbone of our response, is to figure out, okay, if I'm a person and I have a positive test and my funds are limited and I can't go anywhere, what am I going to do, right? And it's our responsibility to help meet that need too. And a lot of that is, again, just supporting partners in doing it. There's very, very little the health department can do on its own in this town and anywhere. We rely so heavily on partners to help meet just the crazy amount of need that we have.
Absolutely, and that is something that BIPOC KC kind of really recognizes the importance of, is investing and doing our best to kind of work with partners and build coalitions with folks in Wyandotte. I think it's a big part of the reason why I recognize a lot of the people on here, but also why I think there's a lot of momentum around trying to improve elements of health equity in the region. And so that was part of what I was going to ask, is that why beyond just dealing with COVID, why is it so important for the health department to work and to be a part of, but also to lead some of these coalitions made up of community partners as they work on issues of health equity?
That's a really good question. And the truth is that health departments have a unique singular mandate. So we are the only one in the county whose responsibility it is to care for the health of every single human in my county. So the reason I left healthcare in the Twin Cities, which was a place I loved and a great job, is that I was tired of my population I was serving being people who are registered as a client with us. To me, that does not move the needle. Health systems are incredibly important, but there have to be entities who see the entire population and every one of our 165,000 residents as our responsibility. That's what the health department's mandate is, right? And so we work with BIPOC KC, we work with a whole bunch of you who are on this call, and you all have a niche, which is fantastic. You're the experts in that area, but none of you can have a niche that covers every single person and every single topic, right? So the same, it can be said for us, where we have some niches. There are a lot of areas where we are not experts, but what we can do is speak to the health of the entire population, speak to the disparities that are there, and try to figure out how do we leverage all of these various partners that we have to move us in one kind of coherent direction.
Sure, absolutely. And I think the last thing that I kind of want to touch on before we start going to audience questions is that 2020 is also an election year. And so in the midst of both the pandemic and the election year, sort of, are there additional steps that the UG is working on, or are there additional departments that you are working with even more now than you were before, to not only make sure that people are able to survive this pandemic, but also continue to be able to do the important work of a community, such as electing officials?
You mean departments within the unified government?
Yes. Mm-hmm.
Yeah. You know, it's an interesting question. I've been thinking a lot of the last couple of weeks as we've started to, in public health emergency response, you conduct after action reports whenever there is any public health emergency. And so we're conducting our first one of the last several months to figure out, are we really learning as much as we can as we go on this thing, right? It's a really important exercise. But I think, you know, the interesting thing here is that we have had an opportunity during COVID to make partnerships very quickly, right? And it's been fascinating as a new director because I needed to embark on these relationships anyway. But, you know, in the last few months, I I don't know the number of times me and the deputy chief over in the police department have had late night phone calls about a situation they're seeing or them wanting guidance. And the same can be said of fire and EMS. The same can be said of our human resources, of our parks department wanting to know which kind of events they can allow on their properties, of our public works department. So every department, every significantly sized department in the unified government has had to interact with the health department in some way over the last many months. And my staff and I have really prioritized those and do our best to be extremely responsive to them, because I see it as us having our foot in the door now and getting to build these relationships that we can leverage later on other health related issues that are going to arise. So I would say yes, almost all UG departments, and in a very positive way, COVID has strengthened those relationships.
For sure, absolutely. Well, thank you again. Like Liz said, if you have questions, members of the audience that you want to ask, feel free to drop them in the chat box, and we will be happy to ask them. We got a lot of good submissions beforehand, and I'll actually be asking a few of those. But for folks who heard something good in the conversation, please feel free to just drop in questions, and like I said, we'll do our best to get to everyone's questions before the end of the hour. So kind of to jump into the audience questions, like I said earlier, there were some really good ones that we got when people were registering for the event, and so I wanted to ask a few of them. And the first one that we got was from Kendra Burgess with The Whole Person, and she said, how can we incorporate accessibility for people with disabilities into the broader strategies of the UG's work?
Yeah, spoiler alert, Michael shared a few of these with me early on. I don't know if you mentioned that. And this one stopped me in my tracks. And it stopped me in my tracks because I realized that I do not have a good answer to this question. And I think what that is showing me, and something that I actually spent a good amount of time last night thinking about, is the fact that there is not representative on our health equity task force that represents this population. And I think that's a serious omission that we need to think about. To go back to the thread of looking internally first, last fall we conducted an ADA accessibility assessment of our building as a health department, and we failed in ways you can't even imagine. And so since then we have created a prioritization list of what are, first of all, some of that low-hanging fruit we can knock out with better signage that's fairly inexpensive, with workarounds. But then how do we start to think about how we budget in improvements that we need in order to become not just ADA compliant, but meet the needs of our community, right? So it's again one of those areas where I'm really glad the question was asked, and I hope it keeps getting asked. And it's one of those ways that the community, just by virtue of this conversation, is pushing the health department to think differently. So I will be the first to admit that I don't think that we have given that community what it deserves, and that I think we need to seriously think about that.
Sure, and kind of going off of that, you've mentioned several times in the conversation the Health Equity Task Force. Would you be willing to give a little bit more explanation about what they do and who their current membership is?
Yes, and there are a few folks on this call who are on that task force, and I'm hesitant to try to list off the membership because I'll leave people out, but we knew early on, within our first 3 to 4 weeks of data coming out from both COVID tests, the positive cases, and our deaths, that our Black population was extremely disproportionately affected. And very interestingly, that trend has segued, and now our Latinx population is much more affected. But the point being that, we used the data. So right out the gate, we were looking at where are the disparities in our community. And we saw especially that disparity with the Black population, and said, we can't sit in a silo in the health department and make decisions by ourselves, assuming that those are all going to be equitable and the right decisions made. And so how do we get other people to the table to help us make those decisions? And so, it's one of those things where we are building it as we are flying it 100%. Again, we've had incredible luck getting folks to come to the table and actually put in the work between meetings. That group for a long time was meeting twice a week, and now still meets every single week. It's an incredible commitment. And that team has just come together. But I think one of the really powerful things is that they are setting the stage for a long-term coalition or organization, whatever you want to call them, we're now starting to think, does this become a 501c3? Does it stay embedded in the health department? How do we make this a sustainable long-term thing? Because there's so much equity work to be done outside of COVID that this can just lay the foundation for us to just take off as COVID dies down a bit eventually, and allows us to think about other things.
Absolutely. And so that kind of ties in. So the work to address specific disparities along the lines of equity is kind of ties in with the next question that we have from the audience, which is from Bianca Garcia. And she asked, are some lower income neighborhoods seeing higher rates of COVID-19 due to a lack of transportation to get tested?
It's a hard link to make, right? So we don't know how many people in the community aren't getting tested, and for what reasons. You know, we may have some ad hoc conversations and stories with people who've heard from others. I'm not going because I'm scared. I'm not going because if I get a positive case, I'll be told to not go to work and I can't afford that. So we, you know, anecdotally, we know there are serious barriers to some people getting tested. I think the front end of the question, you know, are lower income neighborhoods seeing higher rates of COVID? Yes. It's the same neighborhoods that have higher populations of our Black and Latinx population. So there's no surprise there at all. The tougher part is trying to continually keep our pulse on why are people getting tested or not getting tested. And that's something, again, where the Health Equity Task Force has participated, just because they go back to their organizations and to their constituents and collect information and bring it back to us, that the health department doesn't always hear. You know, a lot of the time we are one step removed. And so we rely on the CHCs, on the NBC CDCs, on the churches who are intimately connected with their community to tell us what they're hearing. And so that's one way that we're trying to go about that.
Sure. And kind of going along, and that kind of ties into some of the other elements related to that, is how significant do you think that having additional ways of accessing the testing beyond just drive-through, so having things like walk-up options, how much do you think that has helped to make testing not quite as intimidating and maybe a little bit more accessible for members of the community?
We hope a lot. We have tried really hard to reduce every barrier that we can, right? So I mentioned getting out into the appropriate communities. We do not require a government ID to get tested. We charge nothing. You do not have to have insurance. So we are continually refining our testing to try to get to the point where there are limited barriers. But I think the trust thing that you kind of allude to is massive. And that's why so many of our pop-up sites have been so effective, is that churches are a place of trust. Community organizations are a place of trust. And so if I'm undocumented, would I rather go to the health department or to my church down the block in their parking lot, right? It's a no-brainer. It's just so easy to understand. So I think, you know, we're trying to get creative. I am getting a little nervous. At some point, we'll have to move testing out of the health department parking lot and find a longer term home for it, because we really need to resume a lot of our services. And also we're starting to think about what the heck happens when the weather turns. But so we continually are trying to take potential options for moving our testing to community members. We took some options to the Health Equity Task Force again to make sure that we're soliciting feedback from the community before we make a major decision like that will impact whether or not somebody comes for testing.
Sure. And Broderick Crawford, someone that we both know pretty well, has mentioned in the comments that once pop-up testing in the community began, the resident response was much higher than what had originally been done by the health department. So thank you for making that point, Broderick. And it does tie in with another sort of question kind of going along those lines, is how much, or how has the health department worked to kind of address some of those social barriers? So I know you've mentioned trying to have things like people who speak some of the various languages that are spoken in the community, such as Spanish, Swahili, and others, and trying to go to social institutions rather than sort of bureaucratic institutions, kind of like the health department. But are there additional elements that the health department is considering to try to break down some of those social barriers and encourage people to get testing and other resources that they might need?
To some extent, yes. I mean, we're trying to be creative as possible. I think we've done an okay job and continually can get better at our communications as well. So we routinely, send folks to be on various radio stations, especially the Hispanic speaking radio stations. We try to use a number of platforms of social media and traditional media to reach certain populations. Especially print media that we know our older population are more likely to consume than our younger population. We've really tried to transition to not be only electronic based. So for pop-up testing, we've done, things like send postcards to every address within a 1 mile radius of a pop-up testing site. So people know, especially for our older population who routinely receive the mail and actually paying attention to it. So the communications factor has been a fascinating for us and is one that every couple of weeks is evolving as we realize, oh, there's something we forgot here. And again, that's one of the reasons why our partners have been so instrumental is that they've evaluated those for us and they're giving us the feedback of the people on the ground of how they're experiencing those communications.
Sure, absolutely. And so to kind of switch in terms of the next question we have is from Sarah Hoffmeyer, and she asked, how does building health connect to local food systems?
A big question. I mean, it's everything, right? So it goes back to access and it goes back to built environment. It's the closest thing and the only thing you can get to on foot from your house is a 7-Eleven on the corner, then that's where you're going to go. Again, this is one of those things that I think sometimes we make it harder than it is. The truth is that people need options that they can get to on foot or a bicycle or via public transit. And no foul meant against our public transit department, but that is an area that we need to do better. And we need to do better as a health department and other departments advocating for appropriate resources for expansion of lines and potentially considering free ridership for Wyandotte County residents, which is something we would love to see, right? And so it's all one big question of accessibility. But I mean, the food thing, it's one of a human being's most basic needs. And if we can't get that right, we're not going to get much else right. And so it's again, one of those areas where I feel like the health department has a stronger role to play than we're currently playing, that I'm hoping we can get further into. But the Merck and the Dot Mobile Grocer do have me hopeful that there's some movement on that front in Wyandotte.
Sure, absolutely. Let me see. I think the last audience question that we have, at least for this point, is how can we, is from Josh Steed, and it asks, how can we better connect Johnson County and Wyandotte County to support each other and the region's long-term goals?
That's a great question. I think it's a tough one. So we've had this really kind of unique thing happen because of the nature of COVID. So health department directors have authority over a health department, right? Our health officers, who are often contracted staff, and ours are contracted staff through KU, have a unique set of powers laid out in state statute and can do certain things. And then there are decisions that commission electeds can make, right? And so one of the reasons why it's been really difficult, like as a core 4 or a larger metro area, is that there are so many individuals and positions of power in each of our jurisdictions, and you have to navigate all of that. At the same time, county commission has the right to fire a health officer. And so I give that example to say that it's super messy, but it's not impossible. So amid all of that mess, we have managed our 4 health departments, at least in the core 4, to have some really constructive conversations that have pushed us in some new directions. So sharing resources and contracts related to contact tracing, sharing methodology of how we're coming to some of the numbers and indicators that we're using. We have a conversation in a half hour to talk about gating criteria for schools across the metro. So as much as possible, trying to figure out we know there are very different politics occasionally between Johnson and Wyandotte County, but there will always be points of agreement. And how do we take those and really run with them, especially when those points of agreement are along the lines of science and we can get our larger community to buy in. So I would say our health department relationship with the Johnson County Health Department is very strong. Their new director has come to the table. And so I think that'll really open the gate for us as well in the next few years.
Sure, absolutely. I'm trying to see, sorry about that. I'm trying to see if there are any questions I don't think I see any. See a few other really good comments from folks like Andrea. Oh, we do have one more question from Matt Kleinman. How can the health department help facilitate health equity discussions between departments moving forward? For example, restoring a park intersects with many different departments, but those departments haven't always talked to one another. Are there any plans for how cross-department coordination during COVID can continue to be enhanced post-COVID? Thank you for that question, Matt.
I love that question. Solid plans, no. Ideas, yes. So something that I mentioned my particular passion for working on violence, something we've been thinking a lot about, and I've talked to county administration to some degree, is about helping departments see their role in various topics that they may not completely understand, right? So again, one of them is violence. And there's a lot of time this thought that violence is a police department problem, right? And so I have promoted the idea, and I'm hoping to get some traction on it, I don't know, that we would put together a task force, for lack of a better word, with decision makers in all the departments, so that we're talking about violence collectively, we're understanding the situation collectively, and that every department is helped to understand what their role is. I don't care if you're in parks or public works or EMS or PD or the health department, you have a role to play in violence prevention in our community. So until we start coming to the table and recognizing that these are shared problems, we're not going to get there. I could see that same model being used for food access or for housing. Again, with housing, that's a great example. There are so many departments that can influence that and can promote positive housing solutions in our community, and we are sitting in our silos. And so I hope we can get some traction for the idea that we have to look at these projects and problems together, and also that when we talk about something like violence, this is not implying that the police department isn't doing their job. Or when we talk about housing, this is not implying that livable neighborhoods or whoever else in the UG, EcoDevo, is not doing their jobs. It's admitting that these are incredibly complex social issues and that we all have a part to play, and we're not going to get very far until we all figure out what our part is. And so that is my hope. I'm one person in the UG, but there are several very, very competent and proactive directors in UG departments now that I feel like we are moving in that direction, which seems to be the answer at the end of a lot of my responses today, but that's where we are.
All right. Well, again, thank you for the conversation. I am going to turn things back over to my colleague Liz to sort of wrap things up and take us out of here.
All right. Thank you, Michael. Thank you, Julianne. This has been a really great conversation. I am not a KCK or Wyandotte resident, but can I tell you how encouraged I am to hear such, hold on a second.
Oh, you're fine.
I'm watching my nieces today, so we have a health emergency of a burned finger.
Oh, no.
All right, do you want to sit on my lap or do you want to sit here? Okay. All right. Okay, so here we go. So thank you all for joining us today. I really appreciate it. I'm really encouraged by all of the, like Julianne said, proactive ideas for collaboration and coordination within the UG and within the health department itself to improve the lives of everyone who lives in Wyandotte. Works in Wyandotte, visits Wyandotte. It sounds, I'm encouraged by that. So thank you all for joining us and for listening in. And thank you for your great questions. This has been, we received, like Michael said, we received really excellent questions, and you've all have asked some great questions in the chat box as well. This kind of engagement is what we're looking for, because what we want is we want discussion and conversation about how we can all work together. So thank you very much. Following up, I will send you all an email tomorrow that will include some links that have been listed in the chat box. We've got some great community partners that have offered some advice or some links to various resources. I'll include those. I want to thank you all for coming. Just to close up, I also want to thank our funders. Many funders around the area have been, and around the country, have graciously flexed their funding for this year, because as we all know, we are working through a pandemic and priorities have changed. So we appreciate our funders for sharing their support with us and supporting our community. Thank you to the Health Forward Foundation, the Hall Family Foundation, Enterprise Bank, My Sidewalk, the Shoemaker Foundation, and of course, our members and our sponsors from BIPOC KC. We really appreciate all of you for helping us do this very important work and continue these important collaborations and partnerships. Thank you all for sharing with us today. I'll follow up with that email tomorrow. And thank you, Julianne, for joining us. This has been an excellent program. I appreciate it. Have a good afternoon, and we'll talk to you later.